Michelle from Physioactive Indonesia. Today we will be addressing a medical specialized care known as palliative care. According to an article published in October 2021 by the World Health Organization, over 52 million people, of which 25 million of them each year in their last years of life are in need of palliative care. 78% of those are actually from low or middle income countries. Overall, only 12% of people get palliative care when many more need them. Today we have with us Dr. Sandeep Bhagat, Board of Palliative Care Victoria, Head Unit of Palliative Care in Peninsula Health, and Adjunct Lecturer at Monash University, Australia. How are you, Doctor?
Thank you very much, Michelle. Thank you, Physioactive and Michelle in particular, for talking to me about palliative care. Palliative care is a philosophy of care which we provide to people who have terminal illness, that means they are likely to die in the next 12 months, progressive illness, and an incurable illness. It is not just about physical illness that we focus on, it is also about the care of the family, care of the person, holistically looking after their psycho-emotional, social health, and making sure the remaining life, and I stress the point here, we are looking after the life of the person who has got an incurable diagnosis, and making sure that life is free of symptoms, suffering, and we focus on their wishes, and we affirm them as humans. So that's what palliative care is about.
Okay, so who is actually eligible for palliative care and what does the treatment entail, Doctor?
I'll give you an Indonesian perspective on it. According to the 2020 cancer registry, there are just under 1 million cancer cases in Indonesia. And as we know, some of the key symptoms and care issues in cancer patients are pain, nausea, vomiting, feeling weak, feeling guilty that they might have done something wrong in their life. So we need to address those issues. And often when we talk about cancer care, what comes to doctor's mind is chemotherapy, radiotherapy. That's actually a part of it. But if we need to expand holistically, we need to address the other issues, their psycho-emotional health. So what it involves is managing pain for a lot of cancer patients, making sure whilst they are receiving chemotherapy or radiotherapy, their pain is not an issue. Their symptoms such as their looks, such as their nausea, vomiting is also addressed. Often these things become second option. And in a country like Indonesia, which is quite different from Western world, the number one cancer is breast cancer and cervical cancer. Just these two cancers, and just from culturally sensitive point of view, from gender sensitive, the woman may not complain about pain, they may not express freely their emotional issues. So we need to be more proactive in offering them that care. So what it involves is pain management, it involves a psychosocial, emotional counseling, and giving family and the person an insight into their own illness, making sure that they don't feel guilty about it. It's not their fault they got cancer. And sometimes cancer carries stigma, for instance, in our society. And we really need to address those issues as a team.
So taking you back a bit, Doctor, can you give us a bit of background? When did this whole concept of palliative care come about? Is it a new thing? Because it's something that we don't hear of in Indonesia, or we have not heard of in Indonesia at all, actually.
Even in developed country, well-established countries, so the birth, we can say Canada, UK, that's from where the specialty from 60s, late 60s, hospice care, like giving that care to dying people in a place that's not really medically driven, but we are addressing their overall care. So it's not that new. However, in 2021 as well, only about 10-12% of people who need palliative care are actually getting. in many ways, countries like, who are developing and progressing rapidly, such as Indonesia, India, and other developing countries, wealthy people suffer more. They got all the money, they got this world-class hospitals that can offer interventional care. But you can't keep ventilating a dying person in coma forever. We need to accept that everyone's going to die, and if all the organs are failing and the cancer is advanced, we must accept the person is dying. And now we change the focus of care from interventions to the holistic, addressing their pain and so on. So it is still work in progress even in developing countries, and in developing countries it is a relative new concept because doctors are expected to cure people, make them better, and doctors see themselves as a failure to admit, say, we can't give you any more treatments, but we can offer you care though. So the care should never end. So relatively newer concept and long way to go. And in developing countries, I think the challenge is to make sure not only the poor gets palliative care and care, but it's the very rich people who get unnecessary interventions, and those should be avoided as well if they are dying.
Okay, and in this team, who are the people involved?
The bulk of the care is hands-on care by the nurses, and we have spiritual care workers, depends from which faith. In my team, I've got Christian faith, I have a Muslim faith person, I've got a Buddhist and a Hindu. So it depends on the patient's wishes. Some people really want to talk to a priest at the end of their life, so we organize that. We have speech pathologists to assess their swallowing. Some people can't swallow because all the muscles weaken with cancer. We have dietitians, we have physiotherapists, we have occupational therapists to address the needs of those people. With most illnesses that are very advanced, in the last 12 months of their life, people become weaker. Therefore, the physiotherapy is not about strengthening them, it is about making their function as best as possible with what they got. And for them, it could be just how to shift from your bed to chair. And that's a big goal of the physiotherapy in those patients.
And what are your thoughts on helping out people with this respect, as opposed to, you're a doctor and you, like you said, you help to cure people, or doctors are supposed to help to cure people. How do you feel personally about this segment of work?
So as a palliative care specialist, my role is to really first listen to patients' views, their wishes, and let them talk, let them express them. I must give them the comfort of professional space that they can express their views to me. So it's handing over control to them. Most people, when they have an illness that can't be cured, they are in loss of control. So it's actually first affirming them, respecting them as a live person and listening. And second, to explain to them, I get asked about, oh, is there any other treatment we can do? What about stem cells? What about this trial? So I give them my honest opinion based on the evidence, saying all those are there, whether they will benefit to that particular person. So I give my professional opinion on that. Thirdly, and most importantly, I make sure that unnecessary, unproven therapies are not done. If patients still insist, I would respect that, but I must be honest in saying, I hear you, I know you want to get better, but this treatment is very unlikely to work, so that the remaining time of their life is not spent in the hospital corridors, but that time is spent with the family. What matters the most to the person. If it means for them to be at home with their family, I'll organize that. And I've got a community palliative care team where nurses would visit them daily or as required, and the other professionals will go and see them, because it's very hard for them to get into the car, to come to the hospital every week, every day. It can be very tiring.
And does palliative care have any correlation with psychosomatic disorder?
So if you look at the psychosomatic disorder, which is a psychiatry diagnosis, otherwise there is no life-limiting illness such as cancers or heart failures or last stage of diabetes, then that's a standalone thing. However, most people who have an illness which is going to cause death in the next 12 months. Those people understandably emotionally distressed. Therefore, we do address their psycho-emotional health. And we have counselors, we have spiritual care practitioners who try to address these issues. And often from spirituality point of view, and I'm not talking about religion here, spirituality, their belief into why they got this diagnosis and the questions about their life, such as why me, what did I do wrong? And there are a lot of non-smokers who get lung cancers, for example, and they question this. I'm so young, why did I get cancer? So try to address those issues, not with the medicines only, but also making sure we can counsel them, we can explain to them about their diagnosis.
Okay. And can you share with us some of the experience you've had with the patients, doctor?
I have been honored and I feel privileged to be able to be with people in the last stages of their life and last days of their life, and sometimes I'm holding their hand as they die. I've heard amazing stories, such as someone we thought, as a specialist, I thought they will not survive next day. They are breathing the way the people would in their last hours of their life. And they kept going because they were waiting for a relative to come from UK overseas. And as soon as that person arrived, this comatose person who's been in coma for days suddenly opened eyes, smiles, and then they died. And then I also see people where the loved one who wanted to make sure, husband, wife, that they want to be there for them at the last breath. They are holding their hand for days together, and just for a minute they've gone to the bathroom or to get coffee, the person died. Now what I've learned, there is no science to it, but as a specialist physician, my observation is that people will choose a time, and I explain to the families, if your loved one dies when you're not there, respect it as their choice. On the other hand, if they want you to be there, they will wait for you no matter where you are. So either way, I believe the person lives in their family forever until they live, and those memories will live forever. And it's important to explain this to them so they don't live their life in guilt, or why did I go to the bathroom, or why wasn't I there for them? Because that guilt and that painful bereavement can be harmful for the surviving members. And that's what I said before, it's not about the care of that person, it's also about the care of the whole family.
Okay. Well, do you have anything else to add, maybe for our viewers to know about?
I really like to thank you for starting this conversation. From working in a Western health system for many years and over 2 decades, and as a palliative care specialist, we have a long way to go, but we do need to start somewhere. So I congratulate you on this important conversation, and I guess we'll only go forward in terms of helping out people with their pain and suffering with incurable illnesses. Thank you very much.
Thank you. Thank you, doctor, for your time. For our viewers, if you are interested in speaking with Dr. Sandeep Bhagat, you can either go online at www.myspca.com.au or call +61 406 666 742. On behalf of our entire team at Physioactive Indonesia, we want to thank you for tuning in.